The following surgical technique is Acumed's suggested method for implanting the AccuLock-2 Volar distal radius plate. The AccuLock-2 Volar distal radius plating system is designed for fracture fixation and osteotomies of the distal radius. There are two families of AccuLock-2 Volar distal radius plates. The AccuLock-2 standard VDR plates are silver in color, and the AccuLock-2 proximal VDR plates are gold. The AccuLock-2 proximal plate family is designed to sit more proximally than the AccuLock-2 standard plate family. Both the AccuLock-2 plate families offer 5 plates for the left, 5 plates for the right, and come in narrow, standard, and wide widths to accommodate varying patient anatomies. For fractures that extend proximally into the radial diaphysis, both plate families offer 2 longer length options for the standard and narrow plates. For fractures that extend farther into the diaphyseal region, Acumed offers the unique ability to extend the lengths of the AccuLock-2 proximal long and wide plates with the AccuLock-2 extension plates. There are 2 different lengths of the extension plates. The first is the neutral extension plate, which extends the AccuLock-2 proximal VDR plates by an additional 43 millimeters and can be used on both the left and right VDR plates. Left and right specific long extension plates are also available and extend the AccuLock-2 proximal plates by an additional 111 millimeters. The patient's forearm is supinated to expose the surgical site. To maximize exposure, a towel is placed under the wrist, placing it in extension. A longitudinal incision is made approximately 6 centimeters in length, just radial to the FCR tendon, to protect against injury to the palmar cutaneous branch of the median nerve. The tendon sheath is opened and the tendon is retracted radially to protect the radial artery. The flexor pollicus longus is identified by passive flexion extension of the thumb interphalangeal joint and is retracted ulnarly to protect the median nerve. Next, the pronator quadratus is identified by its transverse fibers and is released radial to ulnar to expose the fracture site. The brachioradialis may need to be released from its insertion on the radial styloid to facilitate reduction and visualization of the fracture. Once the fracture is reduced, provisional stability can be achieved and evaluated under fluoroscopy. Once the appropriately sized VDR plate is selected, attach the corresponding targeting guide to the plate by threading the cannulated locking bolt into the proximal ulnar 2.3 mm screw hole. The locking bolt can be inserted into multiple distal screw holes through the targeting guide. It is recommended to utilize the proximal ulnar screw hole, as that is typically an optional hole for screw placement. This may be done on the back table prior to insertion. The proximal shaft of the chosen plate should be placed parallel to the radial shaft. The plate is designed to sit along the distal aspect of the radius to support the volar articular fracture fragments. Several instruments have been developed for the AccuLock-2 system to assist with plate placement. Radiopaque positioning posts have been integrated into the radiolucent targeting guides to assist with plate placement under fluoroscopy. To verify plate placement, a radiopaque styloid post is utilized in an AP view to project the trajectory of the most distal styloid screw. To align styloid screw placement, position the wrist under fluoroscopy in an AP view and adjust the plate so that the positioning post targets the styloid tip. This verifies correct trajectory of the styloid screw prior to drilling. To verify plate placement from a lateral view, line up the 2 parallel radiopaque posts. A single plane is created by the goal posts beneath the subchondral bone, showing trajectory of the distal screw row. If the posts do not target into the joint, then the distal screw row will not either. This can be achieved by lifting the hand in neutral rotation so that the forearm is 20 degrees to the OR table. A plate positioning handle is also available in the AccuLock-2 system. The handle assists with precise plate placement while minimizing radiation exposure to the surgeon's hands. To utilize the plate positioning handle, thread the locking bolt into the left side of the keyhole on the distal end of the plate positioning handle base. Once threaded into the base, the locking bolt toggles to fit left and right plates. Thread the locking bolt into the most distal 3.5 mm locking hole on the shaft of any left or right Acculock 2 plate. Under fluoroscopy, the handle extends the length of the plate shaft's projection against the radial diaphysis in an AP view. This is used to accurately place the proximal shaft of the plate in alignment with the center axis of the radial diaphysis. The plate handle can be used in conjunction with the radiopaque styloid post and the targeting guide for precise plate placement. Once the desired position is achieved, secure the plate with 054 K-wires or plate tacks. Plate tacks can be used in proximal K-wire or screw holes only. The first screw to be placed is a 3.5 mm non-locking cortical screw through the slot in the plate. Using the 2.8 mm drill and the drill guide, drill to the far cortex. Drill depth is then measured with a depth gauge. Insert the appropriate silver 3.5 mm non-locking screw, taking care that the screw is the proper length. The screw may need to be downsized after the plate has been reduced down to the bone. Utilizing the radiopaque positioning posts in the targeting guide, the position of the plate relative to the radiocarpal articular surface can be fine-tuned by sliding the plate proximally or distally under fluoroscopy with or without the plate positioning handle. If the radiopaque posts don't target the joint, the distal 2.3 mm screws will not either. To further assess the position of the distal 2.3 mm screws relative to the radiocarpal articular surface, place an 054 K-wire through one of the K-wire holes in the targeting guide closest to the joint and assess its location under fluoroscopy. Insert the drill guide into one of the distal screw holes, followed by the 2.0 mm drill. Screw length is measured by using the laser mark on the drill or depth probe against the scale on the drill guide. Individual locking drill guides are also available in the system as an alternative for drilling and measuring the distal screw holes. Screw length can be read off of the laser line on the drill or probe with a locking drill guide as well. There are three options of 2.3 mm screws that can be used distally. There are fully threaded locking screws, smooth locking pegs, and non-locking screws. Insert the appropriate locking or non-locking screw using the 1.5 mm driver tip, screw sleeve, and silver driver handle. It is at the discretion of the surgeon when to use the different screw options. Using the same process, drill and insert the remaining screws in the distal row. The two radial styloid screws are approached from the back of the targeting guide. The radial styloid screws are designed to specifically target and support the radial styloid. Insert the drill guide into either styloid hole located in the dual slot on the back of the targeting guide and continue the same screw placement process for both styloid screws. Be sure that the radial styloid screws are fully seated before removing the guide. Alternatively, the guide can be removed after drilling to increase visualization of the holes when inserting the screws. It is recommended that every screw hole in the distal row be used as well as the two radial styloid holes. For additional support of the lunate facet, the optional proximal ulnar screw can be used. In this instance, the cannulated locking bolt acts as the drill guide. Remove the locking bolt and targeting guide once you have drilled, and insert the drill guide and probe to determine screw length. The proximal locking 3.5 mm screws are then placed. Insert the threaded drill guide, drill with a 2.8 mm drill, and measure off of the laser line on the drill or with the depth gauge. Insert the proper length 3.5 mm locking screw using the 2.5 mm driver tip, screw sleeve, and blue driver handle, taking care that the screw does not exit the bone dorsally. Using the same process, place the final locking screw. Perform a thorough radiographic evaluation, checking fragment reduction, alignment, and screw placement. Verify that there is not a gap between the bone and the plate in the lateral view, and that the distal screws have not penetrated the radiocarpal joint. Close the wound and support the wrist according to bone quality and stability. Allow for early functional use of the hand and start immediate finger range of motion and forearm rotation post-operatively. For specific questions not addressed here, please contact your local Acumed representative or Acumed directly, either at 888-627-9957 or on the web at www.acumed.net.